who needs no introduction. Mark is our senior colleague in Sheffield and is president-elect of BOFAS. He's going to talk about his experience on the role of osteotomies and Cartiva to manage Freiberg's disease. Over to you, Mark. Thank you.
Thank you very much, Maneesh, and good evening, ladies and gentlemen. Very grateful to Education Committee to inviting me to speak this evening. Very grateful for Togai, because without his help, you wouldn't be listening to me, seeing me, or watching any slides because of my IT issues. Also just looking forward to being educated myself by my fellow speakers, because this isn't somewhere where there is dogma that we can talk to you about. This is just a little bit about opinion and our experiences. So I'm going to be talking to you about Freiberg's disease and how I view the role of osteotomies and potentially Cartiva with options for some of the more difficult parts of Freiberg's disease. So I've got no disclosures on this topic at all. We all know that this isn't a particularly common condition. Some of our colleagues that do more forefoot procedure work may see more of it than others, but I don't think that it's common amongst us as foot and ankle surgeons. We know that it tends to affect adolescent females, but again, as years have gone by, I've seen a whole age range of both males and females with the condition. Classically, it affects the second metatarsal more than the third, but again, I've seen that in both of them in the same patient. So it's really quite curious. Now, you're not here logging in online for me to talk to you about ibuprofen and special shoes. You're wanting to have a little bit more in terms of surgery. That's the meat and potatoes. Now, you won't be disappointed to know, but this expert systematic review from our good friends and colleagues, Tim Daniels.
Sorry, Mark, we can't see your screen, so I can't see your presentation. Can you share it, please?
Sorry, I thought, okay, beg pardon. So let me just see if I can do that again. Do you want me to start from the beginning, Maneesh?
Whatever suits you, Mark.
Can you see that now?
Yes, we can. Thank you.
Right. So I won't go through the whole of my preamble again, but I'm basically going to be talking to you about the surgery. Now, I hope you can see this now, but essentially quite a good systematic review that was written by our friends Tim Daniels and Mark Glazebrook from Canada, which was published in 2019, reviewed all of the English language studies that looked at surgical interventions for Freiberg's disease. And of course, as you'd expect, with something where there aren't any clear-cut answers, there are a plethora of different treatment options and different results. But it's interesting that they concluded that all interventions in the current study have very weak support in literature in terms of efficacy. But the consistent finding is that the evidence to support treatments is all level 4 and 5. So they could only make grade C recommendations from those studies with consistent findings. And that's just useful to bear in mind. So nothing you're going to hear tonight is going to be anything other than expert opinion and experience. Now then, there have been a myriad of techniques that have been written up over the years, as I've alluded to with the Daniels and Glazebrook paper, and there hasn't been a consistent way of thinking about disease severity. So what do I do surgically? Well, what I try and do is customize each of the procedures I might do to each individual's pathoanatomy. And of course, what we've principally based our pathoanatomy on has been the Smiley staging system, which was written in 1957 and was based upon a combination of radiology and surgical findings. If you take the time to read this paper, and it is a very well written paper of its era, but you try looking at the radiographs that they put up in the paper, and therefore what they were using to actually make the judgments on the disease in those stages. And it's really quite remarkable that something from the 1950s has hung around for so long. But yet that is still the case. That is how we base our surgical strategies. So I would say to you that we're using an out-of-date assessment system, because what you don't want to do is use radiographic techniques alone and then get in and see a picture on the right and say, okay, so how am I going to tackle this without having had the pre-warning of some decent imaging? So this is what I would say is and this is what I do, is I get a CT scan. And what I ask the radiologist to do, because we've all got a plain film to reference from, is I ask them to then reformat the cuts of the CT so that they go through along the sagittal alignment of the affected metatarsal. So you can effectively scroll through from medial to lateral through the affected metatarsal heads. And that gives you an awful lot more pathoanatomy than you get from your plain film. And it doesn't half show you some surprises. So you can see on the CT there that there is a loose fragment there. You can see that there's quite considerable loss of bone stock in the dorsal area of the metatarsal head. So get the CT, know what you're faced with, have the information to hand. Scrutinize that met head, look for the loose bodies and assess the extent of the disease. That would effectively be tip number one for you tonight. And essentially, if there is minimal involvement of the head, really a whole load of fragmented loose bodies, etc., then all you need to do is go in and debride them, and you can consent the patient for that. It's accurate consenting. And then perhaps you may wish to do some drilling of any area that looks a little bit indolent and might need some vascular stimulation. So then it comes on to how else I do things surgically. And this is a new classification system from Freiberg's disease that we devised in Sheffield, principally based upon our experience with these sagittal cuts through the affected metatarsal. So what you can see we do here is we start with number one, we put the center of rotation in the center of the head. We draw a line proximally along from that center of rotation on the inferior cortex of the metatarsal, extend it onto the articular surface and create two zones, a dorsal zone or zone 1 and a plantar zone. And you can see there with the three examples that you can assess the severity of the disease based upon that classification system. And it's quite difficult, having devised this, to then prove that it works. But to me, it just seems logical, because you are assessing the severity of the disease by doing this imaging. So here's an example here where we've got zone 1 and zone 2 diseases that have clearly sort of been shown to you. And in zone 1 disease, the decision I make is effectively when it's in the dorsal aspect of the metatarsal head, is then I consider doing a Gautier osteotomy. And Gautier was the paper that was written in Core back again a long time ago, 1979. It was quite a large number of patients, about 60 odd patients, and especially is useful with small arc of disease involvement. And you can see in the schematic on the left side there how a Gautier osteotomy works and is secured with the old-fashioned technique of using a suture. But it's definitely useful. So you can see in the example that I've shown you today that there is zone 1 disease present. I've been able to plan an osteotomy, and obviously rather than using a suture, I've been able to use a screw to derotate the metatarsal head and have the plantar aspect of the metatarsal head engage with the base of P1. So really useful to know that before you even get in to see the patient's pathology. Now with zone 2 disease, this is much more of a challenge. You've got a much wider, more extensive arc of disease that affects the plantar aspect of the metatarsal head. And I think that this really does push the limits of a derotation osteotomy. And it then starts to beg the question is that, well, is it easy just to excise the metatarsal head? Well, then you'll end up with possible problems with metatarsalgia and a floating toe. And that isn't often acceptable by the patient. So these are difficult things to solve, and we might find out more from Al and Kailash about what they would do. So I would suggest to you that potentially Cartiva has a role here, because this is effectively filling that void and giving you something that you can articulate your base of P1 with. Now, there is a little bit of evidence, and it is actually, again, from the Canadian group. It is actually Mark Glazebrook and Tim Daniels again. They published a preliminary paper with 5 cases, a minimum of 15-month follow-up. I know that the team in Manchester have also published on this. My personal experience, again, it reflects all our global experiences that we don't see many cases. I've seen 6 cases since I've been using Cartiva. 2 have been associated with an MTP fusion. My first one I did was back in 2011 with a small implant, and that was my error, but I'll come to that in a minute. But the other 5 I've discharged happy, which is anecdotal, but good to see. And you can see the pictures on the right, exactly how I've positioned the implant. I'll take you through this schematic. Excuse my drawings on a piece of paper. But my tips for doing this are essentially to find the area of disease, debride it, get it back down to stable bone at the base of your debridement. You're looking for the use of an 8 or a 10 millimeter implant, not a 6 millimeter that's too small. And unlike when we've used Cartiva in the past for the first metatarsophalangeal joint, you do definitely place this in dorsally. So you can see that what you do is you put your wire in that you then over-ream with your triple reamer, and you then place your Cartiva implant on the right-hand side. And what it's trying to do effectively is allow the P1 to then abut against the implant as the patient dorsiflexes their toe. So this is an image that shows exactly that. So you can see that the CT has shown really extensive disease that has probably involved, I would say, 120, almost 150 degrees of that metatarsal arc. And the post-operative view, which is never impressive for a Cartiva because you can't see it, but you can see that the P1 is jacked out, and there is something that is restoring the cascade of those toes. This is another case here where you can see, it was one of my cases where there was concurrent first MTP arthrosis, but again, quite extensive disease, destruction of that second metatarsal head, a massive amount of involvement of the articular surface. So I fused the big toe and again put a big spacer in, having debrided the joint. So in summary, my view is this, that the Smiley classification is slightly out of date. It has had its time. I would suggest that sagittal CT slices through the affected metatarsal head are much better in planning what you're going to offer your patients. It allows you to then decide whether or not you're just going to do a debridement and get rid of loose fragments, which is a perfectly reasonable operation to do. Or if you need to do anything more extensive, then to create that surgical zone, 1 or 2, or dorsal plantar, however you want to label it, and consider doing an osteotomy for the smaller arcs of involvement, and potentially consider a Cartiva for those large defects. Thank you for your attention. Sorry for the IT problems.
Thank you very much, Mark. That was excellent. As you said, it's not a very common problem, and it's difficult to do a proper randomized controlled trial or prospective study because of the small numbers involved. And it's all, the evidence is all anecdotal, most of it, and your tricks and tips are extremely valuable, and we are going to discuss it in the discussion section. I would now like to invite our second speaker tonight, Kailash Devalia, who is a good friend and colleague, foot and ankle colleague. I was really interested in him treating Freiberg's disease because I just came across a paper in foot and ankle surgery that Kailash has recently published about their technique of using the autogenous matrix-induced chondrogenesis EMIC technique. So I'm really interested to hear more about their experience and how they do it. And I would like to invite Mr. Devalia, who is a consultant foot and ankle surgeon in Gateshead. Thank you very much, Kailash, and over to you now.
Thanks, Maneesh, for all the nice words. Mark, that was an excellent start of this webinar. So thank you. And thanks to the Education Committee for inviting me to this Master Technique series. So I'm Kailash Devalia from Gateshead. And let me start by sharing my screen. Right. So yeah, Freiberg's disease, as Mark said, it's interesting and it's very challenging. Yeah, sorry, back on the track. I'm not, I think I'm equally good as Mark on my IT skills. So these are the slides that we are going to go through. As I said, it's challenging, and it's challenging for two reasons. You know, when I see these young patients, young girls, mainly girls, you know, sitting in my clinic coming with the Freiberg's disease. And the first question that comes to my mind is, how am I going to take this patient from age 20 to 70 years? Because we all know that, you know, it has got guarded prognosis, and, you know, they present with isolated metatarsalgia, and the natural history is such that they will develop the arthrosis of the second MTP joint and then ongoing issues. I'm not going to go through any etiopathogenesis of the disease. Mark has already gone through this. But when we decide an intervention, we have two surgical goals. One is to meet patients' expectations, and that's to improve pain. You know, can we make this patient pain-free? Can we give them their function back? Can we let them engage into their normal recreational activities, sporting activities, because these are young patients. But at the same time, you know, as a surgeon, we have challenges ourselves that is there anything else we could do to improve the long-term prognosis of this disease? So to meet the first expectation, that is, you know, the patients are improving the pain and improving the function, we believe that there are three sources of pain in Freiberg's disease. One is the impingement pain that comes from the peripheral osteophytes of the lesser MTP joints. The second pain, which is a dull, achy type of pain, which can appear on weight bearing but can be present at rest as well, is due to the ischemic necrotic bone under the subchondral insult that the metatarsal head has faced. And that is very evident on the MRI scan T2 images, where you see the edematous, you know, white images of the metatarsal head. And third is the chondral pain, which is just like meniscal tear pain due to chondromalacia and the loose chondral flaps. So the first goal of the surgery is to improve this pain, and we all do the same thing, I believe. You know, we do debride the joint, we do cheilectomy, we do global excision of the peripheral osteophytes that improves the peripheral pain. And to improve the ischemic pain, we need to remove all the ischemic necrotic bone that is present on the MRI scan. And then we create situation which can improve the circulation by creating some microfracture and opening up the medullary canal. And by doing this, we are already, you know, changing the environment around the lesser MTP joint. And then the final stage is to do chondroplasty, remove any loose chondral bodies, any chondral flaps, achieve stable chondral margins. And by doing this, we achieve our first goal, and that's to, you know, improve the pain. And most patients will be pain-free for some time. They'll be functional. They'll be able to weight bear. But then, as I said, you know, the second challenge is to us, to the surgeons. Can we do anything to improve the prognosis? Can we prevent the relapse? Can we actually attempt to remodel this metatarsal head, can we add some processes so as to improve the biomechanics, so as to stimulate neoangiogenesis, neo-osteogenesis, and neochondrogenesis. And that's where the operation becomes more interesting. And this is included in the second part of our surgical technique. So the first step is to achieve improved blood supply. And we treat this as non-union. When we try to attempt fusion or in non-union situation, what we do is we create a scenario, or we take the steps so as to improve our medullary and the periosteal blood supply. So we open up our medullary canal, we do petaling, we do microfractures, and what it does, the body takes it as a fracture. So body brings lots of blood supply into that local area, and that way we have already improved the biology and achieved our first aim of neoangiogenesis. The second step is now to see whether we could regenerate new bone around this area. And the first thing to do is to remove the dead necrotic bone. So all that, edematous bone that we see on the T2 images of the MRI scan, we have to be a little aggressive and we have to get rid of that bone because it's a dead bone. It's not going to allow a process of osteogenesis over there. So we have to get that out of the bone. We have to treat it as a large osteochondral lesion that we get in talus or in knee. And then we have to look at our intraoperative findings and the pre-op MRI and CT scans. And obviously, there are some classifications Mark already mentioned, but I like to classify it this way, whether this is a contained defect or this is an uncontained defect. Just like the hip surgeons, when they are doing the revision hip surgery, before doing the acetabular revision, they convert the acetabular deficiency from uncontained to contained, and then they implant the cup. Same way, we have to take this metatarsal head or the metatarsal as a cylinder, and we have to see whether there is any deficient cortical shell. The deficient cortical shell will make it an uncontained defect, and our priority will be to convert this into a contained defect. And that will determine our bone graft harvest as well, whether we want only cancellous bone or do we need both cortico-cancellous bone graft. And most times, the bone graft harvest site is the calcaneus. You can get nice juicy cancellous bone from there. I use lateral cortical wall of the cortex, and we don't need much, to convert the uncontained to contained defect. You just need a little cortical shell so as to put it and recreate that cylinder. Once we have improved the mechanics of the bone, now it's a contained defect. We perform impaction bone grafting with the cancellous bone graft that we have collected from the calcaneus, and then we add the bone marrow aspirate on the top. So now we have achieved two steps: neoangiogenesis, neo-osteogenesis. The last step is to get a cartilage membrane on the top. And chondroclide, which is available from G-Slich, it's a porcine mucosa. It has got a smooth surface on the top, which is laid with the chondrocytes, and the undersurface is laid with the collagen fiber, so that faces the medullary canal, incorporates with the new bone graft. Earlier, when I started doing this procedure, I used to design this membrane as per the size and the shape of the defect. But Mark Fanden from Harrogate in last IFAS meeting, he presented a series, his lab findings, where he suggested that the circular defects are able to resist the shear forces more as compared to the other shapes. So nowadays, I convert all the defect into circular defect and put a circular membrane. And main aim is to stabilize the membrane, make sure that it doesn't get displaced. I put all the bone marrow aspirate on the undersurface and then stabilize the membrane with the biocell glue. So now we have achieved all three steps of neoangiogenesis, neo-osteogenesis, neochondrogenesis that should try to remodel the head. So this is our experience. We've done more than 10 cases, but we had 10 patients who had completed 3 years of follow-up. I'm not going to go through the details of the paper, but what is interesting over here that the MOX FQ and the VAS score did improve in all the patients. And more importantly, in the younger patient, the improvement was significant. And I've observed this, the proms, they do improve at every age. But what's more interesting is the remodeling. So this is a 19-year-old girl who presented to me around 5 to 6 years back with the left contained second metatarsal Freiberg's disease. And this is the post-op picture at 3 years. And this is, the second metatarsal head is remodeled almost completely. This is her pre-op MRI scan, and you can see the edematous bone over here. You can see the cortical defect on the top. And this is her MRI scan 36 months post-op. And you can see the regeneration over there, and most of the metatarsal head is remodeled. Interestingly, last year, she came with a similar problem on an opposite foot. And this is her 3 months post-op X-ray. Similar type of contained defect, quite a bit of dorsal bone has been taken off. We did the cancellous bone grafting with the amnic membrane. What's exciting over here, I just can't stop, believing myself that this is similar to the Hawkins sign that we see when the process of revascularization starts. So this is just the 3 months post-op, and remodeling is a slow process, and I'm sure she will develop the same type of result as on the opposite side. This is another 31-year-old man with an uncontained defect. We did the corticocancellous bone grafting and amnic, and again, there is good remodeling. And radiological picture is very good when the patients are young, and we believe that it's because of the biological plasticity. These are the young patients, they've got good regeneration potential, and there is a good opportunity over here to remodel the head, but we still have to, follow these patients for long term to see whether we could actually say with confidence that this does happen and remain in shape at longer follow-up. So this is what we suggest we to follow as an algorithm. We divide our patients into young and old patients, and the Freiberg disease of the joints into salvageable or non-salvageable. Non-salvageable are the one where there is established arthrosis, there's quite a significant bone deficiency, and our options will be Cartiva or excision arthroplasty. But for younger patients where we have got significant bone loss, get the MRI and CT scan. We define our defects, whether it's a contained or uncontained defect. We convert the uncontained defect into contained defect, do the impaction bone grafting, do the amnic procedure on the top, and just wait for the remodeling. I would suggest let's be a part of patients' journey from 20 to 70 years. Give them, 2 decades of good bone grafting and remodeled head, so that we have got some good remodeled bone available for Cartiva if they develop arthritis at a later stage. And once they are low demand, above the age of 60, 65, we perform Stainsby procedure. Thank you.
That was a brilliant talk, Kailash. I'm sure there will be questions in the discussion, but thought-provoking and good work. Well done. So now we are moving towards salvage. And now I am going to ask one of my colleagues in my home turf, Leicester, my senior colleague, Al Best, who is going to discuss the role of Stainsby procedure to deal with cases where you've tried something, it's not worked, and patient is complaining of pain, it's arthritis. So Al is going to talk about the evidence and his own experience about the role of Stainsby procedure to salvage from Freiberg's disease or secondary arthritis due to Freiberg's disease. Over to you, Al.
Hi, thanks Maneesh. Hopefully you can all see me. I'm going to try and share my screen just now. I have to say 2 brilliant talks there, and actually probably makes me a little bit embarrassed to give my talk. I don't think any of us see massive amounts of Freiberg's in general, and also it's difficult to know where to go when primary procedures have failed. So Maneesh asked me a few weeks ago, what do you do to salvage the situation in Freiberg's disease? I said, well, I have done Stainsby's a couple of times in the past. He said, oh, great. Can you do a talk on that? So, so here it is. I'm just going to hopefully share my screen. Let me know if it doesn't come up. But hopefully you can see that.
You can see it, yeah, thank you.
Fantastic. Okay, so role of Stainsby's procedure. Well, oh, it doesn't seem to be moving on at the moment. Let me just try that again. I think I'm having the same problem that Mark had, unfortunately. Let's try this. Ah, there we go. Okay, so what is the evidence for surgery of Freiberg's? Hello, can you hear that okay?
No, we can't see your screen.
You can't see it. Oh, great. Okay, let me just try again. Share screen. Any good now?
Yes, we can see your screen.
Great. Hopefully it will go on the slideshow. There we go. Yes. Is that okay?
Yeah, perfect.
Right. Okay. So first of all, as Mark alluded to earlier, what is the evidence for surgery in Freiberg's? Well, generally, it's quite poor. The other difficulty we have is trying to decide what is a joint sparing and what is a joint sacrificing procedure, because definitions vary throughout the literature. But when people have done systemic reviews, actually the evidence base for joint sacrificing surgery is based on about 70 cases overall. So there's not a massive amount of literature out there to support whatever you do. And almost all of these studies are level 4 or 5 evidence, so case series and case reports. There's an occasional level 3 study. But generally, the evidence for excision arthroplasty in Freiberg's disease is even less. The Sheffield group with Chris Blundell published a common concepts review in 2009, and their conclusion was that once the joint had become arthritic, there's fair evidence to support the use of excisional arthroplasty with the interposition of soft tissue within the joint. Further systematic review in 2015 stated that complete resolution of pain and return to full activity is achieved in about 73% of joint destroying procedures, and that most of the evidence that is available favoured joint sparing procedures rather than joint destroying procedures. And again, as Mark alluded to, in 2021, I think it was published actually, Tim Daniels' group basically said that going through the evidence, most of it is grade C evidence, poor evidence, whatever type of surgery that you do. So what we're talking about really here is Stainsby's procedure, and what do you do when all else fails? As you can see on the picture on the right, you really don't want to be here. So it's certainly not the first option. I think it can be useful if you've tried all of the other options and you've still got an unhappy patient. So salvage after previous joint sparing surgery. I think if they've got intractable pain and especially stiffness as well, a lot of the procedures, primary procedures, do end up with stiff joints. And if you've got somebody who's really not happy with that, then again, Stainsby can be quite useful. Perhaps where there's established degenerative joint disease, it may give a slightly more reliable outcome. But if you've got a subluxed or a dislocated toe, then this again might be the procedure of choice. So hopefully most of you are familiar with what a Stainsby is, but since I'm talking about it, it's best to explain exactly what it is. Firstly, it's mostly used for inflammatory arthropathy where you do have dislocated MTP joints, and there's reasonable evidence for its use, and it's certainly one I use for my forefoot arthroplasties. There's some level 4 evidence that suggests for non-inflammatory patients that Stainsby procedure can give reasonable results. And if you look on the right, what is the Stainsby procedure? Well, again, it is a salvage procedure. It is a resection of the base or a proportion of the proximal phalanx, a tenodesis of the extensor tendon to the flexor tendon to actually stabilize the toe in the right place. And if you harvest the EDL tendon proximally, you can actually roll it up as an anchovy, and you can use that to interpose in between the base of the resected phalanx and the metatarsal head. So I tend to do this through a zigzag incision based over the base of the proximal phalanx. As you can see from the photograph there, if you do harvest the extensor digitorum longus proximally enough, you can then roll it up, and then as you introduce your K-wire with the toe in the reduced position, you can actually put that into the joint and skewer it with the K-wire so that you have the soft tissue into position. Well, it has its good points and its bad points. And as I've said before, you're looking at salvage here, but a lot of surgeons will be familiar with the procedure and pretty comfortable with carrying it out. But I think one advantage of the Stainsby over excision of the metatarsal head is that it tends to avoid the transfer metatarsalgia so much, which is described after single metatarsal head excision. I think also if you've got a patient who is really unhappy with the stiffness after other procedures, then the Stainsby procedure will actually allow you to have a toe that certainly isn't stiff. What are the downsides? Well, there's no doubt that the cosmetic appearance isn't brilliant, especially if it's a single toe rather than all of the toes that are being done. And it does give you a shortened and somewhat floppy toe. And there's an inability to actively claw the toe up because of the tenodesis that you've performed. And revision options, obviously, after a Stainsby are difficult. So this is just an example case. This was a 26-year-old PE teacher, and she'd had a couple of previous procedures done about 10 years before she presented to me. Not entirely sure what had been done previously, but you can see there's some metal swarf in the metatarsal head there. So I presume it was some form of debridement and drilling. And her complaint was that she just couldn't do her job because it was so painful. And also the toe was so stiff that she wasn't able to actually actively take part with her PE classes. And we tried all of the normal conservative measures with injections, shoe wear modification, physio, etc. But really there was no improvement. Now, with her being 26 years old, I really didn't feel that Stainsby was indicated for a primary procedure. But when we got the CT scan done, and I'm so glad that Mark suggested that we get CT scans done, and I would suggest that this is probably a type 2. I didn't feel that a closing wedge osteotomy would really be feasible in this particular patient. And also you can see she's got actually quite a lot of degenerative change across the joint there. So I didn't have any experience with Cartiva or with the AMIC, so I did a soft tissue interposition in her. So I did a COB2 where you use the extensor tendon and reroute it through the joint. And this was the pre and the post. So you can see we debrided the metatarsal head and drilled it, but also I think actually to me that was pretty good restoration of the joint space. And I thought that the X-ray appearance was quite good. Now, initially, she was quite happy with it. It was stiff, but she was certainly the pain was improved. But the results did deteriorate over time. And she had a recurrence of the stiffness. I didn't think it was particularly stiff, but she did complain quite bitterly that she felt it was stiff. And also, she had a recurrence of her pain, couldn't get back to the PE class. Now, at this point, she was so fed up, having had multiple injections again, etc., that she just wanted one procedure that gave her the best chance of having a reasonable outcome. So after counselling her, I did suggest the Stainsby procedure, which we subsequently went on and did. I was probably a little bit too aggressive with the proximal phalangoectomy there. But having said that, a year after the surgery, she was pain-free. She was able to return to her PE class, and she was reasonably happy. Obviously didn't really like the appearance of the short toe, and it was somewhat floppy, but to her, it wasn't stiff anymore. It was pain-free, and she was managing to do her job. So I think in summary, the support and evidence for any surgical intervention in Freiberg's isn't great. A lot of it is opinion and case series. Your joint sacrificing procedures certainly should not be your first line treatment, and I think really you should be using them as a salvage. But I think that excision of the metatarsal head risks transfer metatarsalgia, and certainly the small case series that have been done, although the short-term results are reasonable, the long-term results don't seem to be quite so good. Having said that, there are no reports of the Stainsby being used specifically for Freiberg's, but excision arthroplasty with soft tissue interposition has been reported with fair results. So that's the end of the talk, and I'll hand back to Maneesh.
Thank you, Al. That was a very good, honest talk about this complicated, challenging problem. You talked about salvage procedure, and I think all the three speakers have given us really, stimulating talks to deal with this issue. And I would like all the three speakers to please switch on their videos so that we can kick off our discussion session, because there will be questions. There are quite a few questions. I would like to start with a few questions of mine. So, panel, the first question is, should we be worried about using steroid injection for Freiberg's disease? It's been shown anecdotally that it improves the pain, but is there a worry that it can soften the cartilage, make it worse, etc., etc.? So your individual thoughts, starting with Mark.
I would fully endorse your comment there, that I think it just would add to the underlying problem. I'm not a huge fan of repeated steroid injections, but if you've got a diseased joint which has got a always flaps of cartilage, dead bits of bone, it's not going to do anything. So I certainly wouldn't inject them.
Thank you. Kailash?
I don't inject the forefoot joints. I have done, hindfoot, midfoot joint injections, and this is again where I know that, I'm going to perform a definitive surgery in form of fusion. I would inject, but if I'm performing arthroplasties, and if there is any risk of, infection, I generally prefer not to inject those joints.
Thank you. Al?
I think it depends on the stage of the disease. I mean, the lady that I showed there already had degenerative changes in the joint on both sides of the joint. And I think when you've got the sort of long-term consequences of Freiberg's rather than the more acute stage, then it probably does have a role. But I think I would agree with Mark and Kailash that in the early stages, it may be harmful. There are some studies that suggest that there is an effect on the metabolism of cartilage with steroid injections. So I think in the early stages, I would probably try and avoid them. But I think where there's degenerative change, it's a reasonable option.
I think that's a great, I agree completely. The consensus is that try to avoid it initially due to harm, but later on where the harm is already established, degenerative disease, then that's reasonable to do that. Thank you. Like to develop consensus. You are the experts here. Second question, which I would like to ask Mark about the osteotomy. I mean, you gave a very good algorithm. My question is that why just distal osteotomy? Why not proximal metatarsal osteotomy away from the zone of injury? So say for example, a dorsiflexion osteotomy to just raise the second metatarsal head a little bit so that it doesn't cause that pain on weight bearing. Any thoughts on that?
Well, I think that it's, for me, you're actually dealing with, by doing an osteotomy at the level of the pathology, and that would be my rationale for doing it distally. Partly because actually what you're trying to do is resect that diseased bone. That all comes out in the wash, and then what you're doing is rotating the plantar aspect of the head into a more functional position. And of course, you just don't do that if you do it proximally at the other end of the metatarsal.
Okay, thank you, Mark. The other experts, do they have to add or agree or disagree?
I wonder if you were talking about an extra-articular osteotomy rather than an intra-articular osteotomy, i.e. more of a distal osteotomy, which has been described. And again, it gets reasonable results. My concern with doing a more proximal osteotomy, that you'd actually raise the metatarsal head and you would end up with the same sort of effect of metatarsal head excision and transfer metatarsalgia. So I would agree with Mark that I think an intra-articular osteotomy, if there's enough of the head left, would, to me, seems more sensible.
Thank you. Kailash, do you have any?
I don't perform any osteotomies around Freiberg's disease, but I like the concept of creating some osteotomies around this area. And I believe the basic problem here is the infarction. The metatarsal head has undergone infarction, and any procedure that does increase the blood supply or improve the blood supply in that area would definitely support in the regeneration of the newborn. So if Mark is performing osteotomy close to the defect itself, that will help in the remodeling. But I wouldn't do a proximal osteotomy, as Alistair suggested. There is a risk of elevation, there is a risk of shortening, and then they will come with the the other ray metatarsalgia, which itself will be difficult to manage.
Thank you. That actually nicely brings me to another question from the chat, which was about shortening. So we have said that, we have alluded that Freiberg's disease, one of the reasons to develop Freiberg's disease is length of the second metatarsal being long. So Mark, the question was addressed to you, but I'll ask everyone. So do you think that shortening helps at the same time when you're doing your osteotomy, or length doesn't matter?
I think it's inevitable that there's some shortening with the osteotomy. I only had that one image that I showed you, but if I looked at my other osteotomies over the years, the parabola of the metatarsal heads isn't quite normal. And of course it can't be, because you've resected something and you've rotated and changed the anatomy. So I think it's inevitable, but it's not necessarily a deliberate ploy with the surgical strategy. Yeah, so I think it's just something that has to happen.
Thank you. Just to move on, because we have got quite a few questions. Mark, whilst you're there, I'm just going to ask you about Cartiva. I've got two questions. First question is a political question. NICE has made recommendations about Cartiva for first MTBG arthritis. And Al knows, in my hospital, we had to go through NIPAG and all that, and it has become almost impossible to use Cartiva, even for first MTP joint arthritis. How can we justify Cartiva for Freiberg's disease?
I kind of thought you might ask that, and you've taken out my middle stump. I think basically NICE have said that if you're going to use it, you have to use it and use the BOFAS database. In other words, what you don't do is use it and discard the patients. Now, obviously, I've said that I've discharged mine, but I did that before the NICE guidelines were all formalized, and I haven't done one since they have changed. But I think if I was going to do one now, if I was going to put one in the big toe, I would make sure that we did it properly using the database, so that effectively we are monitoring the progress of these patients with time.
Thank you. And my following question is, how do you salvage failed Cartiva? I know you haven't experienced that, but any thoughts about if Cartiva fails, are you going to send them to Best for Stainsby?
I have done one. So the one I did in 2011, I made a mistake because actually Tim Daniels suggested that I did it because he'd done one, and we agreed that the 6mm implant was the one to use. And she did all right, but she was revised in 2020. So she had 9 years of her 6mm implant, and I put in her 10, and she's doing fine.
So you revised it to another Cartiva?
Yeah, just a bigger one, because I knew the great thing is we knew what size it was, because I remember the patient, she was quite flighty, so she didn't come for any follow-up for a while. So I literally took the old one out, put the guide wire back down, reamed a bigger cylinder or channel, and put in a bigger implant.
Thank you, Mark. Kailash, there is a question in the chat about stiffness following AMIC. Do you think stiffness is a problem?
I don't agree with that. Stiffness is not a problem. I believe there are some surgeons who, after ankle AMIC, keep them non-weight bearing and protected. I do my intraoperative testing. I take the joint to the full arc of movement and observe whether the membrane is stable or not. That's the only reason why they have to remain non-weight bearing. And once I'm comfortable that the membrane is stable, it's not moving, I do allow them full weight bearing, and I do allow them full range of movement. So in my experience, AMIC, it does not cause any stiffness around that joint. No.
Thank you. Just a technical question. How do you stabilize your membrane? You just glue it, or what do you do?
In my practice, I use bone marrow aspirate a lot. So as a part of calcaneal bone graft harvest, I collect the cancerous bone, if required, cortical chips from the lateral cortical wall, and at the end, I take 10 ml syringe and try to collect 2 to 3 milliliter of bone marrow aspirate. And if you have seen the AMIC procedure, you don't have to make the membrane proud. You have to create the defect and keep it below the level of the original cartilage. Once you do that, once you put the bone marrow aspirate, the membrane is generally stable. But apart from that, I use the BioSeal glue at the periphery, and that is more like a gluing mechanism. And at the end, you remove the excess of that glue, and most time it remains stable. I know that there are few surgeons who have done these procedures and they do white krill stitch as well. My worry about is that if you go through the bone, that's fine, but if you go through the cartilage, you are actually damaging the healthy cartilage. So in my practice, I will just use glue or bone marrow aspirate.
Thank you. No, I completely agree with the logic, what you've said. Bone marrow aspirate, why do you think bone marrow aspirate is important? Don't you think that the combination of the seal, chondroglide, and bone graft should be enough? Because bone graft, it's a cancellous bone graft, has got good vascularity. Or you just want to put everything together?
Yes, Maneesh, that's what, as I said, if we don't change the environment, if we don't give the maximum that bone deserves, then it might fail. And what we are trying to do is we are trying to remodel the head. So you take opportunity of every possible ways you can improve the circulation in that area. Every possible way you could regenerate the new bone, and every possible way you can regenerate the cartilage, because that's your aim. So bone marrow aspirate is just going to aid. I know that old surgeons, they used to take the bone marrow aspirate from iliac crest and inject into the non-union area because it has got osteogenic potential. So why not? Yeah, it's just there. Use
no, I agree absolutely. Whilst you're there, why not use everything what is available? One final question on the same thing. Is there, you showed your age classification. Do you follow it? Would you not do this procedure beyond a certain age, or?
I think my experience is not good enough to comment on that. But it's just the general observation that the radiological remodeling is certainly better at younger age. So PROMs have improved at all the age, and most patients are happy. And I believe it's the first 3 steps in the procedure, when you remove all the impingement pain, ischemic pain, condyle pain, most patients will have a good, better functional outcome score. It's the radiological, biological plasticity, which is an advantage in the younger patient. And in a way, we are lucky that most of these patients are young. So, we can use this biological plasticity to our advantage to remodel the head. But I must be honest that the radiological outcome is not as good in the older patient. But I still do that as a first-line procedure rather than doing CAR-T or any other additional procedures.
Thank you. I'm going to come back to L now. L, I have a question for you. I want a solution. What do you say? So I had a patient who I think had Freiberg's. I didn't have the initial X-rays because she was treated elsewhere. But half of the second metatarsal shaft has been excised. So it's aggressive metatarsal head excision, and the patient comes with third metatarsal pain now. What do you do? Do you shorten all the third, fourth, fifth? What do you do?
I think you retire very early. I think that's a tremendously difficult position to be in, because essentially that's almost unsalvageable. I suppose you could shorten down the other rays, but you would have to shorten them an awful long way, and I don't think that would be particularly useful. Off the top of my head, I'm struggling with how you would salvage that, to be honest. Maybe do some elevating. Well, even if you did elevating osteotomies of the other rays, you still don't have the weight bearing under the second. So, is there anything else, or is it just completely in isolation?
It's just the second metatarsal.
So there's no associated hallux valgus or anything like that.
Sorry, I mean, it might be an unfair question, Al, but the thing is that because people are not asking about questions about Stainsby, I have to ask you something. So I asked the difficult.
You'll have to ask me that one.
Okay, now I've got a few more questions for all of you. I mean, I know what the answer might be, but the question is there a role of arthrodesis for Freiberg's disease? Just say yes or no, quickly.
No.
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 Thank you. Is there a role of PRP injections?
No.
I don't do PRP injections. No.
Yes, no?
No.
No. Okay. Any role of drilling?
Yes.
Yeah.
Please elaborate. Those who are answering yes need to elaborate.
Well, if you remember from my talk, if you go in and you just simply going in and planning to debride, there'll almost certainly be a loose chondral flap. And if you take away that chondral flap, there's often a little patch of bone that just needs to be removed. And then I drill to, again, change the biology, as Kailash has eloquently suggested.
So, Mark, is it drilling in conjunction to debridement? It's debridement.
Yes.
Okay. Periosteal flap. Last question. I'm not going to take it. Is there any? So the question I think Kailash is directed to you. Is there any use of or experience with periosteal flap if IMIC is not available? So they are saying they haven't got the chondroglide. Can they just use a periosteal flap?
Interesting question. I would counter question, where do you get that periosteal flap from?
I mean, I was thinking that, but I thought you might. Yeah, it agreed. It's difficult to find any periosteum, isn't it?
I mean, you could do the petaling as I suggested, to increase the periosteal blood supply, but to get a periosteal flap in these adults, it will be difficult. At a young age, under the age of 18, you may get nice juicy periosteal flap and we can use, but these are mainly patients presenting in 20s, 40s, 60s. I don't think you will get any good periosteal.
In essence, no role. No, look, thank you so much, all of you. I really, really enjoyed the session with you guys, and I've learned a lot of things. I would like to summarize, and if you may permit me to sort of my thought processes, that if somebody has got young patients, as Kailash group as suggested, there is a good role for the procedure of trying to restore the biology, the biomechanics by doing cancellous bone grafting, injection to stimulate healing, and then seal it with a sealer, chondroglide. Role of Cartiva, I think Cartiva is a possibility in middle-age group patients where there is some arthritis, but obviously we do need to counsel our patients because Cartiva is not yet proven, and you can talk about Cartiva as trying to see it's something between Kailash and L, that you can try something, and if it doesn't work, then the salvage procedure, where somebody is, for example, 60 years old, either they have multiple procedures, they've got established arthritis, then you consider Stainsby. Is that a fair take home?
Yeah, don't forget an osteotomy.
And I forgot osteotomy completely. When would you do osteotomy then? Before Kailash or after Kailash? Or no Kailash?
No, I think, Kailash is one, Kailash probably falls a little bit in that sort of specific zone 1 area where, you have to look at your CT scan. I could see that Kailash's technique would be very useful. But if you have quite a broad area of head that is not right, but it doesn't go towards the plantar surface, then an osteotomy is probably an easier thing to do.
Thank you so much. In the interest of time, I would like to close this session down. The QR code for the feedback, I'm sure has appeared or will appear soon. Please use the code for the one for the feedback after scanning it. Do not forget the date for another exciting Master Techniques webinar on 22nd of June at 8 p.m. And thank you once again, all of you, for joining us, and the speakers who gave their time and shared their experience, and the IT team, especially Toge, for once again doing a brilliant job. Thank you very much, everybody, and have a good night.